Hello friends, I am Dr. Deepak Garg. I am an orthopedic surgeon and today we will discuss about bone tumors. So when we look at the x-rays, so to define the lesion in the x-rays, what all points we need to see? We look at the age, we look at the location in the bone, whether this is epiphyseal, metaphyseal or diaphyseal. Then we look at the margin, whether this is a well-defined or a ill-defined margin. Then we look at the zone of the transition, distribution, whether this is geographic, permeative or moth-eaten. Then finally the matrix. So there is a separate video that we have made for the reading the bone tumor x-ray. So these are all the points that we cover in the x-rays. So we should know about all these points. Then we look at the age-wise classification, like why the importance is given to the age. So if the tumor is occurring in less than 10 years of the age, the most commonly it should be a Ewing sarcoma, unicameral bone cyst or a neuroblastoma. If age is more 10 to 20 years, then the chances of osteosarcoma and ABC are more. 20 to 40 years, giant cell tumor, adamantinoma and chondroma. More than 40 years, Mets, myeloma, lymphoma. So Mets, myeloma, lymphoma are the most common after the age of 40 years. So from this we can understand that the first decade most common tumor is Ewing sarcoma. Youngest malignant tumor is Ewing sarcoma, and the most common primary malignancy overall is the multiple myeloma. So we should understand this and we should remember this. Then we should look at the location of the tumor, whether the tumor is epiphyseal, metaphyseal or diaphyseal. Let's look at first at the epiphysis. So the most common tumors in the epiphysis are chondroblastoma, giant cell tumor and clear cell chondrosarcoma. So now we know that the giant cell tumor is after the age. What was the age of the giant cell tumor? So we go back to the previous slide. It was 20 to 40 years. So the giant cell tumor occurs in 20 to 40 years of the age group and after the physeal closure, that is after the physeal closure after 20 to 40 years. So and the location is epiphyseal. So if we have a patient with a epiphyseal tumor, a locally aggressive tumor in the age group of 20 to 40 years, then the most commonly it can be a giant cell tumor. Similarly, the chondroblastoma is in the physeal epiphysis region and it is before the physeal closure. So if it is after the physeal closure, it should be GCT. Before it is chondroblastoma. Clear cell chondroma is usually seen in the adults. So these are the epiphyseal tumor. So the pure epiphyseal tumor before fusion is chondroblastoma. Then we look at the metaphyseal tumors. So the metaphyseal, most of the tumors are metaphyseal. Osteosarcoma, chondrosarcoma, osteochondroma, enchondroma, ABC, UBC, osteomyelitis. So these are all metaphyseal tumors. So metaphysis is the growth zone. That's why most of the tumors occur in the growth zone, that is in the metaphysis. Then last is a diaphyseal tumor. So diaphyseal, Ewing sarcoma, lymphoma, multiple myeloma, adamantinoma, osteoid osteoma. So these are the tumors that usually occurs in the diaphyseal region. So let's say we have a diaphyseal tumor with an onion peel appearance, then the answer is Ewing sarcoma. So let's discuss about the radiological patterns that we see in the tumors. So if the patient is having a sun ray appearance or a Codman's triangle, then the most commonly it is osteosarcoma. Onion peel is seen in the Ewing sarcoma. Soap bubble appearance on X-ray is seen in the GCT or adamantinoma. Ground glass appearance is in the fibrous dysplasia. Punctate calcification is in the chondroid tumors, because what happens, the chondroid tumors, there is a interrupted calcification. And homogeneous calcification is in the bone. So the bone will have a homogeneous calcification, like this is the white area. And then fallen fragment sign is seen in the unicameral bone cyst. So then we look at the cystic bony lesions. So the main cystic bony lesions are UBC and ABC. UBC is SBC, simple bone cyst. So simple bone cyst is seen in the first decade, less than 10 years. And ABC is seen after the age of 10 years, 10 to 20 years. And the location of SBC is central, whereas ABC is eccentric. So if this is the bone, This is the central location and this is the eccentric location. So eccentric will be ABC, centric will be UBC. Then the fluid that we aspirate is a straw colored in ABC, in it is blood. And MRI will show a single cavity where there will be fluid level with septations in ABC. Treatment of UBC is curettage and ABC is extended curettage. And pathognomic sign, if we see, fallen fragment sign is a pathognomic of simple bone cyst. Double density level is a pathognomic of aneurysmal bone cyst. So aneurysmal bone cyst is a pseudocyst, whereas simple bone cyst is a true cyst. Then we look at the osteochondroma. So this is a osteochondroma. So what are the features of the osteochondroma? So it is a developmental lesion. This is not a true tumor. This is a pseudo tumor. This is a developmental abnormality. So it is seen in childhood to adolescent period, and it starts from the usually developing area. This metaphyseal is a developing area of the bone, and it starts after the skeletal maturity, as the bone growth will stop after skeletal maturity. So there is a cartilage cap over the tip of this bony osteochondroma. So the thickness of this cartilage cap is very important. If this thickness is more than 2 cm, there are higher chances of malignancy. Otherwise, most of the times it is benign. The most common location is distal femur, proximal tibia, that is around the knee. And it will usually grow away from the joint. It will not grow towards the, it will be usually away. It is of two types, pedunculated and sessile. Pedunculated means it is attached to the bone, and the one we are seeing here in this picture is the sessile. So this is sessile. If the patient is having pain, then the most common reason is bursitis, because it is usually painless. And X-ray will show the bony outgrowth with the cortex. It is continuous with the parent bone. So it is continuous with the parent bone. So this is a hallmark feature. And malignant changes are very rare. And if the patient is having pain and growth after the maturity and the cartilage cap thickness is more than 2 cm, so these are the red flag signs. So immediately we have to do intervention. Then if we look at the associated syndromes, multiple hereditary exostosis is associated with this, and patient can present with the multiple deformities bowing sometimes. And treatment is usually either observation, or if it is symptomatic, we can just excise it along with the periosteum of the parent bone. So this is the treatment. And the most common benign tumor is the osteochondroma, and the most common true benign tumor is a osteoid osteoma, because this is not a true tumor, this is a pseudo tumor, this is a developmental anomaly. Then we have a osteoid osteoma. So we can see this is a tibia and this is a cortex, and we can say this is a lytic lysis and surrounded by the sclerotic lesion. So lysis surrounded by the sclerotic lesion. So this is how it appears on the X-ray. So this is a benign tumor, and it is usually seen in 10 to 30 years of the age group. The cell of origin is a osteoblast or osteoclast. So this is the cell of origin, and most common site is a femur more than tibia, and it is seen in the cortical region, as we already know. And the hallmark feature is a night pain that is relieved by the aspirin. And this nidus, this is called nidus, which this is the part that we are watching here. This nidus is less than 2 cm. And central X-ray will show a central radiolucent nidus surrounded by sclerosis. Best imaging is CT scan, as we have already seen here. This is a CT image, and this is showing the best axial plus sagittal coronal images. And if we get a bone scan in this patient, bone scan will show a focal intense uptake. And the treatment in these days, the most common is RFA, radiofrequency ablation. Then we have a giant cell tumor. We already know that this is in the after the age group of 20 to 40 years after epiphyseal fusion, and in the epimetaphyseal region. So we can see this is in the epimetaphyseal region, and the already mature skeleton. So it arises from the stromal cells or the mononuclear cells. So the metastatic cells will be the mononuclear cells. If it metastasize, it will be mononuclear cell. But it is a benign tumor, so the metastasis is very rare. It is around 3%. So when we do the histology, it will show the giant cell. That's why it is called giant cell tumor. These giant cell are osteoclast like cells, and most common location is around the knee, distal femur more than proximal tibia. Other locations are the radius, as we can see here in our example, it is the radius, and patient will clinically present with pain, swelling, or sometimes reduced joint movement. On palpation, patient may show egg cell crepitus, and histology will show numerous giant cells in mononuclear stroma. The treatment is extended curettage with bone cement. Extended curettage means we will use a high speed burr. So high speed burr is compulsory in GCT. So then is enchondroma. Enchondroma is again a benign tumor. The most common is in the small bones of the hands and the feet, and this is usually seen in the young to middle age group. This is a benign tumor, and the cell of origin is a chondrocyte. So mostly we can see this is mostly seen in the metaphyseal or sometimes in the diaphyseal, and the most common is the small bones of the hand. Other sites can be femur or humerus. It is usually painless and usually an incidental finding. Patient comes for something else, we get the x-rays and incidentally we find this. Systemic signs are usually absent in this. X-ray, we can see this is a well-defined lytic lesion. So well-defined lytic lesion in x-rays. If we look at the DDs, it is bone infarct, and syndrome associated is a Ollier disease. High risk syndrome is a Maffucci syndrome. Malignant change is very rare, and the treatment is usually observation, sometimes curettage. Then chondroblastoma. So we already know this is in the epiphyseal region before the physeal closure, so less than 20 years. So this is the growth plate. It is not yet closed, so this is less than 20 years, and the lesion in the epiphyseal region. So one of the DD should be chondroblastoma, and this is a case of chondroblastoma. Cell of origin is a chondroblast, and the bony location is epiphysis. Common bones: proximal humerus, distal femur, proximal tibia. And clinical features, so because it is around near to the joint, there can be pain and swelling in the joint, sometimes restricted motion also. Systemic signs will be absent. X-rays again will show a lytic lesion with stippled calcification, and margins are usually sclerotic. So characteristic calcification is a chicken wire pattern on that which is seen on histology. So histology will show chondroblast and giant cells. So treatment is again either RFA or sometimes with the curettage. Then we have the chondrosarcoma. Chondrosarcoma is a malignant tumor. It is not a benign tumor. So it is usually seen in after the age of 40 years. And this is a cartilage forming tumor. Most common location is in the pelvis, and followed by the proximal femur, humerus, and other bones can also have chondrosarcoma. So it is usually a metaphyseal tumor and usually central, where the medullary cavity is involved, as we can see here from the x-rays. So this is some lesion. Here we can see some calcifications here, and this is a ill-defined margin, so we cannot define the margin here. So this is a case of chondrosarcoma. So patient may present with a deep dull pain, and systemic signs are usually absent. The X-ray will show some calcifications, like we can see here the interrupted type of the calcifications, and here we are not seeing, but sometimes there may be a cortical thinning, and that is called endosteal scalloping. So cortex will become thin like this. So endosteal scalloping is a X-ray sign of chondrosarcoma. Cortex is usually thinned out or sometimes breached. Histology will show malignant cartilaginous cells. It can be a primary or secondary chondrosarcoma. Secondary will usually have a origin from the either enchondroma or osteochondroma. They convert to chondrosarcoma. So the most common malignant tumor of the hand is chondrosarcoma. So we should think about it. They are asking malignant tumor, not benign tumor. So most common benign tumor of the hand should be enchondroma, but they are asking malignant, so malignant is chondrosarcoma. Then we have the fibrous lesions. The fibrous lesions are fibrous dysplasia like. So this is a X-ray showing a fibrous dysplasia. These are usually developmental lesions. These are not tumors. These are developmental anomalies. So they are not true tumors. So the pathology is the normal bone is replaced by the fibrous tissue or the woven bone. This is during the developmental phase, usually seen in the childhood or the young adult. It has two forms. Monoostotic means single bone involvement. Polyostotic means more than one bone involvement. Most common site is femur, and the other sites can be the craniofacial bones. Then it is usually polyostotic. Location can be epimetadiaphyseal. Any location can be. Clinical feature will be pain, swelling, deformity. Sometimes patient present with fracture also. Characteristic deformity in the femur is a Shepherd crook deformity. X-ray will show ground glass appearance, and the cortical feature is a Rind sign. So there is a lesion. It is for have a sclerotic rim. There is a lesion for have a sclerotic rim. This is called Rind sign, thin sclerotic rim. This is a feature of the fibrous lesions. Then we have histology will show Chinese lateral woven bone in fibrous dysplasia. Syndrome associated with McCune-Albright syndrome. So the patient is having a fibrous dysplasia because this is not a true tumor, and so we do not intervene if the patient is asymptomatic. We just observe. If patient is symptomatic, then we may have to fix it with the plate or rod. Then we have the osteosarcoma. Again, this is a malignant tumor. So this is a bone forming tumor usually seen in the second decade of life, and cell of origin is a malignant osteoblast. And this is a bone forming tumor. Location is usually metaphyseal of the bone, and most common site is around the knee, distal femur more than proximal tibia. This is patient will present with progressive pain and swelling. So X-ray will show sunburst appearance as we can see here, and sometimes with the Codman's triangle. So the Codman's triangle is this showing the aggressive lesion. Bony destruction can be mixed lytic plus sclerotic because it is a bone forming tumor, and histology will show the lots of osteoid tissue, and most common site of metastasis is to the lung. So the most common primary malignant bone tumor in young is osteosarcoma. The treatment is again first we give chemotherapy, then surgery, and then give adjuvant chemotherapy. So this is how it is treated. Then we have Ewing sarcoma. So Ewing sarcoma is also a malignant tumor of the bone. It is seen in the younger age group, first and second decade, and the cell of origin is a primitive neuroectodermal tumor, and nature it is a marrow based tumor. It is not only from the bone cells, it is from the marrow cells, so it will have a systemic feature also, and raised ESR-CRP will be there because of this. The location is can be diaphyseal, and the most common site is femur. Patient will present with pain, swelling, and fever. So it has a systemic sign also, raised ESR-CRP. X-ray will show this, as we can see here, the onion peel appearance on radiograph. And histology will show the small round blue cells. So they are also called small round blue cell tumor. IHC is very important in this, and they are PAS positive, and CD99 and MYC2 are positive, and they have a peculiar genetic translocation, that is translocation 1122. So 1122 is a translocation hallmark of Ewing sarcoma. Metastasis is lungs more than bone marrow. So for the metastatic workup, we always get a bone marrow biopsy also for Ewing sarcoma. Treatment is again first we give adjuvant chemotherapy followed by surgery, and then neoadjuvant chemotherapy. So this is the treatment of Ewing sarcoma. Then we have this multiple myeloma. So this is the most common malignant tumor of the bone. So it is usually seen after the age of 40 years. It is a malignant plasma cell tumor. The cell of origin is a plasma cell, and multiple bones are involved in this. Most common is a spine followed by ribs, pelvis, skull, and other extremity bones. Clinical feature: patient will present with the bone pain, fatigue, severe back pain not relieved by anything. Systemic feature: the mnemonic is CRAB, C for hypercalcemia, renal failure, anemia, and bony lesions. So this is these are the systems involved in multiple myeloma. So the X-ray will show punched out lytic lesions, and the bone scan is often negative in multiple myeloma. And osteoclast activity is increased. That's why there are multiple bony lesions, lytic lesions in bones. And serum ALP level will be usually be normal. And on blood tests, M band will be positive. Serum electrophoresis M band will be very, very high. Plasma cell on bone marrow will be more than 10%. And on histology, plasma cells with cloak face nuclei is seen in multiple myeloma. So metastasis, common primary, like the most common tumors that metastasize to the bone are the breast, bronchus, lungs, thyroid, prostate. So these are the tumors that usually will go to the bone, and kidney, renal tumors. So osteoblastic metastasis will usually be from the prostate. Osteolytic can be kidney and thyroid. Spine is the most common site in the breast. So we should know these points. So let's just revise it. Night pain plus aspirin is osteoid osteoma. Epiphysis before fusion, chondroblastoma. Epiphysis after fusion, GCT. Diaphyseal plus fever, Ewing sarcoma. Metaphyseal plus sunray, osteosarcoma. Skull punched out, myeloma. Pelvis plus calcification, chondrosarcoma. So this was about the bone tumors. Thank you for watching this video. Now the next video we will come up with all the MCQs about the bone tumors. We will come up with the 300 MCQs in the next video. Thank you guys.